Bismillahirrahmanirrahim. Assalamu alaikum and good morning, everyone. Thank you very much for joining us for the gastroenterology grand rounds this morning. I am Dr. Shamail. I'll just briefly go through some of the ground rules, which I'm sure all of you will know by now. We will be inviting your questions and your comments towards the end of the presentation. So I'd really appreciate if you could just keep your microphones muted through the presentation so we can avoid interruption. A recording of today's grand round will be made available on the social media channels of Maroof International Hospital for those who've missed it. It is a great pleasure to introduce to you our speaker, Dr. Osama Tariqat. Dr. Osama is a consultant gastroenterologist in Maroof International Hospital. He's a graduate of Dow Medical College, Karachi. He received his fellowship training from SIUT Karachi and completed his FCPS in gastroenterology in the year 2014. He subsequently did a 2-year fellowship in the transplant hepatology from Shifa International Hospital, Islamabad. Dr. Osama also worked as a research fellow in the Institute of Liver Study, King's College Hospital, London. His main areas of interest are HCV treatment, liver transplantation in acute on chronic liver failure, and liver transplantation in hepatocellular carcinoma. Today, Dr. Osama will be talking to us about how to safely and effectively prescribe medications to patients with hepatic impairment, which I'm sure will be of a lot of help to all of us in different areas of specialization. So that said.
Okay. Thank you very much.
Turn it over to.
Okay, thank you very much, Dr. Shamail, for the kind words. Hope my voice is clear.
Yes, it's clear, Dr. Osama.
Okay. Today, grand round topic is prescribing medicines in patients with hepatic impairment. I'm Dr. Osama. I'm an associate consultant gastroenterologist in Maroof. So in the next 40 minutes, our learning objectives will be how the liver disease is classified. Then we will be going through common signs and symptoms of liver impairment. And lastly, how to ensure medicines are safely used in patients with liver impairment. Now, liver disease is very common and its incidence is increasing. According to the Global Burden of Disease Project, which was done in 2015, there was an estimated over 1 million deaths globally, which is around 2% of all the deaths. And a further 1 million deaths were attributable to acute hepatitis and liver cancer. Now, this liver disease can manifest in a broad spectrum of conditions, which can range from mild and self-limiting disease to the severe disease, which have very high mortality. Coming to the prevalence in Pakistan, approximately 5 million people are affected with hepatitis B and 10 million people are affected by hepatitis C, which is according to research done by WHO in 2016. And according to that research, 23,720 people died of hepatitis-related causes in Pakistan, which is compared to a bus full of 64 people every day. And thousands of new patients are added every year because of the lack of prevention and testing and treatment resources, inadequately screened blood transfusion, improperly sterilized invasive medical devices, and with the use of unsafe injections. Now, this liver disease is classified according to both the pattern of damage seen and the time over which the damage occurs. And the two main patterns of damage of liver disease are cholestatic liver disease or the hepatocellular liver disease. And according to the time over which this damage occurs, the liver disease can be acute one, in which the symptom of onset doesn't exceed 6 months. And when the symptom of onset is more than 6 months, then it is known as chronic liver disease. Both the cholestasis and hepatocellular disease can lead to fibrosis and cirrhosis. And cirrhosis is a progressive disease, which is defined as fibrosis and nodular regeneration, which results in disruption of the normal architecture of the liver. Now, when the cirrhosis occurs, it can be compensated, and later on it can become decompensated cirrhotic. In compensated cirrhotic, the liver is able to carry out more of its function, but when it is decompensated, then the liver is extensively scarred and it is unable to carry out most of the functions. Normally, the healthy liver goes into beginning of the liver damage in stage 1, then the moderate liver damage, significant liver damage, and then the stage 4 is cirrhosis. On the histopathological images, we can see that the normal liver has properly aligned hepatocytes and sinusoids, but as there is cirrhosis, it forms nodules with fibrous tissue. Now, when this disease progression occurs in patient with compensated cirrhotic cirrhosis, we can determine the next 10-year probabilities of becoming decompensated cirrhosis, with ascites occurring in 47% of the population, with the compensated cirrhosis in the next 10 years, hepatic encephalopathy in 28%, and gastrointestinal bleeding in 25%. And of the 15% patient who have diagnosed to have ascites die within 1 year, and 44% within 5 years. So this shows the extensive high mortality of patients with cirrhosis. And since it is a silent disease, so we can say that these patients have very high chances of mortality and disease progression. Common causes of liver disease, most common are viral hepatitis B and C, chronic alcoholism, non-alcoholic fatty liver disease. Then comes the immunological causes, including the autoimmune liver disease, primary sclerosing cholangitis, the different biliary causes. Genetic causes include the Wilson's, hemochromatosis, alpha-1 antitrypsin. Then we have Budd-Chiari and the cryptogenic causes. The sign and symptom of liver disease, we all know that the basic signs are jaundice, and when the patients become decompensated, they can have ascites, they can have portal hypertension and varices, esophageal and fundal varices with different grades of encephalopathy. The initial acute symptoms may include pale stool and dark color urine, presence of gynecomastia, fatty stool, spider nevi on the skin, finger clubbing, and symptoms of pruritus. So we can see this is a typical spider nevi. This gentleman has finger clubbing and deep jaundice, which is a sign of liver disease. Commonly, there are a number of tests which are used to determine the impaired liver function, but the commonly available tests are the liver function test. We have different scoring symptoms, the Child-Pugh score and the MELD score, which determines the severity of liver disease. So this is the chart for child score. It has 5 parameters. 3 parameters are lab-based and 2 parameters are basically on the basis of examination. And each parameter has been assigned 3 points. The serum albumin, serum bilirubin, INR, presence of ascites, and encephalopathy. And as the total number of score increases, the child class also increases. The more the score, the more the liver is damaged. And based on the child score, we can see that as the child score increases, this is a child A, which is 95% 1 year survival. It dropped to 90% in 2 year survival. But as we can see that the patient with child C cirrhosis, there is a 1 year survival of 45%, which drops to 38% in 2 year survival. So what is the effect of liver cirrhosis on drug handling? So the liver has a wide range of functions. It is one of the most essential organs for metabolism of drugs. When the patients are unwell, the metabolism of drugs will be abnormal. And this results in the accumulation of drugs or their metabolites, and which results in increased risk of side effects. The different causes of impaired drug handling in liver cirrhosis includes the liver cell necrosis. There is shunting of blood through the portosystemic collaterals. reduction in the concentration of drug binding proteins, there is abnormal drug volume distribution, there's altered drug elimination, altered drug metabolism, and pharmacodynamics. When the patient becomes decompensated, there are chances of associated renal failure, and of course there is drug-drug interactions. And this impairment of drug metabolism is proportional to the liver dysfunction. Then the patient with well-compensated cirrhosis, they have nearly normal synthetic function. But as the liver becomes decompensated, there is significant synthetic dysfunction and portal hypertension. Generally, the drug handling depends on the patient factors, which include the severity of the disease, trends in the liver function and synthetic liver function, as I've already mentioned. And then the specific drug factors, which includes the route of administration, pharmacodynamic, pharmacodynamics, the therapeutic index of every drug, and the different side effect profile. Coming to the administration of drugs, general rules are that the oral route is generally preferred in patients with liver disease. Modified release or long-acting preparation should be avoided, as the dose can accumulate in the body. Intramuscular injections should also be avoided because it can lead to development of hematoma at the injection site, since the platelet count are on the lower side and because of anticoagulation disorders. The topical preparation and patches may cause increased irritation to the skin in patients with liver disease, but again, in certain diseases, as with the presence of pain, we can apply the fentanyl patches. If rectal preparations are given, first of all, their assessment should be made for the potential presence of rectal varices and the increased risk of bleeding. The different pharmacokinetic factors that affect the bioavailability in patients with liver disease include reduced absorption, then the volume of distribution, because there is decreased binding proteins, presence of cachexia and the presence of ascites, and then the metabolism of the drug because of altered hepatic blood flow, liver enzyme capacity, and the type of metabolic reactions. And certain groups of drugs should be prescribed cautiously in the following conditions, because in ascites, the drugs which contain high sodium can cause water and salt retention. Presence of coagulopathy can potentiate the anticoagulation and the NSAID side effects, and encephalopathy can increase with the use of sedative, hypnotics, and the CNS depressants. The use of diuretics and constipation agents can also increase the encephalopathy. So, general factor to consider when prescribing in liver failure includes the underlying diagnosis, INR, albumin, and bilirubin, as I've mentioned in the child PUC score, our overall goals of care, and trend in liver function or the disease progression status. The general approach in prescribing medicines include avoid hepatotoxic drug, ideally use drug with shorter half-life. If raised INR or prothrombin and bilirubin, consider dose reduction. And start with a small dose, increase slowly or dose as required. Monitor patients closely with regular review, and for each symptom, a thorough assessment, including history, examination, and investigation, should be undertaken. Coming to the individual complaints that most of the liver disease patients come through. First, I'll start with the symptom of pain. Ensure thorough clinical assessment regarding type and cause of pain. Use verbal and non-verbal indications of pain. Different pain scores should be used. Involve patient in discussion about treatment choices where appropriate. First, consider non-pharmacological management of pain. Then follow the WHO analgesic ladder to ensure adequate titration of pain control. Avoid the transdermal or slow release preparation unless liver function or the pain is stable. So this is the WHO analgesia ladder. With a mild to moderate pain, we can give the non-opioid aspirin, NSAIDs, or paracetamol. Usually in liver diseases, the NSAIDs are not given. We usually start with paracetamol. Then as the severity of pain increases to mild to moderate, we can add the mild opioids, and with severe pain, the other options are used. Regarding the first step, that is the use of paracetamol, IV route should be used with caution in patients with hepatic insufficiency, chronic alcoholism, chronic malnutrition, and is contraindicated in cases of severe hepatic insufficiency. Initial dose of acetaminophen should be less than 2 grams per day, and patient with cirrhosis having visceral or musculoskeletal pain should be treated with acetaminophen less than 2 to 3 grams per day, and consider dose reduction in patient weighing less than 50 kgs. Regarding NSAIDs, it interferes with the platelet aggregation and can prolong the bleeding time. There is increased risk of GI ulceration and hemorrhage, and renal impairment is increased in patients with hepatic impairment. So the general rule should be the NSAID should be avoided in liver failure and liver diseases. Regarding the opioid analgesias, there are different factors which increases the opioid level in patients with liver disease, including the reduced first pass metabolism, high plasma concentration of more lipid-soluble drugs in the cachexic patient, increase in free fraction of protein-bound drug if low albumin or high bilirubin is present, and cholestasis may reduce the elimination of morphine and codeine that will eventually increase the levels in the blood. And there are certain factors which also reduce the opioid level, which include the presence of ascites. The distribution of water-soluble drugs in ascitic fluid may reduce the amount of available in the circulation, and impaired metabolic capacity may decrease the conversion of drugs to active metabolites. General side effects of opioids in liver dysfunction which should be considered include the constipation, which this may precipitate encephalopathy. So always when the opioids are prescribed, laxatives should also be given. These opioids can increase the drowsiness, which can worsen the encephalopathy. Also, tramadol can lower the seizure threshold and could precipitate seizures in these individuals. Opioids can increase pruritus, and the biliary side effects can be there. In some patients, opioid also increases the pedal edema because of their antidiuretic actions. So general rules for all opioids should be start at the lowest dose possible, carefully titrate and monitor for clinical response and adverse effects, co-prescribe laxative, avoid controlled release preparation and opioid with long half-life, and consider increasing the dose interval. So this is the chart for the medication use with pain control. Start with paracetamol, which is used in which is safe in chronic use with caution in acute and severe disease. It should not exceed 3 grams per day. Usually it should be 2 grams, but maximum dose should be the 3 grams per day. NSAID should be avoided because it increases the chance of bleeding. Regarding the opioids, tramadol should be avoided in severe disease, and whenever it is given, it should be given in the low dose of 50 milligram twice daily up till 100 milligram twice daily. When the pain is more severe, we can give the morphine, which is at a dose of 10 milligram 8 hourly, or we can apply the transdermal patch, which is fentanyl patch. Gabapentin can be used for neuropathic pains, which is safe in liver impairment, but used with caution. due to the different sedative side effects. The starting dose should be 100 milligram BD and it can be titrated slowly. Dose reduction in renal impairment is required, and the different side effects of gabapentin include drowsiness, tremor, peripheral edema, leukopenia, and gynecomastia. But we can start gabapentin at the dose of 100 milligram BD. The second most common symptom that is commonly encountered in patients with liver disease includes agitation. So the essential drugs in palliative care for symptoms such as anxiety, agitation, or as an anti-epileptic is benzodiazepine. The benzodiazepines are highly protein bound in plasma and extensively metabolized in the liver to active metabolites. Benzodiazepines with long half-life can accumulate when given repeatedly, and undesirable effects may manifest only after several days. This can lead to coma in patients with hepatocellular disease when given at normal doses. And the second problem we all know is that there is tolerance and dependence may occur with long-term use. Adverse effects of benzodiazepine include dose-dependent drowsiness, impaired psychomotor skill, cognitive impairment and hypotonia, and an increased risk of falls. The general rules should be the short-acting benzodiazepine can be considered if clinically indicated, and longer-acting benzodiazepines may be used, but doses should be reduced and the dose interval should be increased. The first-line benzodiazepine that can be used in patients with liver disease is Diazepam. No significant increase in clearance and half-life of Diazepam in cirrhotic patients, generally given by oral or sublingual route, and the onset of action is within 5 minutes. A sublingual route and 10 to 15 minutes in upper oral route. Second, midazolam, onset of action 5 to 10 minutes subcutaneous and 2 to 3 minutes IV. Generally used for agitation or seizure control in terminal phase. It is also used buccally for seizure, so can be administered at home and used with caution, reduced dose and increased dose interval. Usually during the endoscopic procedure, we use midazolam. Diazepam increase half-life in cirrhotics, so generally use first line for status epilepticus if no IV access, and generally avoid in liver impairment because of the longer half-lives. Then clonazepam is generally reserved for use in refractory seizures or for severe neuropathic pain if oral route not available, and it should generally be avoided as the first or second line treatments. So coming to the different sedatives, lorazepam is usually the first line benzodiazepine, which is usually given as a dose of 0.5 milligram twice daily. Midazolam is the second line benzodiazepine. 2 milligram IV is usually given with a maximum dose of 3 to 4 milligram. Diazepam is the first line drug for status epilepticus, and clonazepam is basically used for uncontrolled seizures or severe neuropathic pain with a dose of 1 milligram once daily. Coming to the nausea and vomiting, these symptoms can be because of two different reasons: mechanical motility problems because of external pressure from the hepatomegaly or gut wall edema, or because of centrally mediated nausea may result from presence of raised bilirubin or other toxins. Also, patients with liver disease have increased GI transit time, and such patient may benefit from taking a prokinetic agent. Centrally acting antiemetics should be used with caution and avoided if possible in patients who are encephalopathic. Domperidone, that is motilium, is a drug of choice due to its side effect profile. It does not cross the blood-brain barrier. When the child score is more than 7, the dose should be reduced by 50%, and the maximum dose is limited to 10 milligram TDS. It can prolong the QT interval, and prolonged use should be avoided where possible. Metoclone, that is the metoclopramide, is the first line for gastric stasis induced nausea and vomiting, but the dose should be reduced by 50% in patients with severe disease. One of the side effects is that it crosses the blood-brain barrier and hence causes extrapyramidal effects, dystonia, cardiac dyskinesia. It can also cause loose motions, cholestasis, and formation of AV shunts in the liver. Ondansetron onset, it is widely used in the hospital setting in the post-operative patient after chemotherapy and radiotherapy induced nausea and vomiting. It is used in intractable nausea and vomiting due to chemical, abdominal, and cerebral causes when usual approaches have failed, and reduce maximum daily dose to 8 milligram in patient with moderate to severe hepatic impairment. The dose should be reduced. So regarding the antiemetics, domperidone should be the drug of choice as it doesn't cross the blood-brain barrier, and but the dose should not exceed 10 milligram TDS. Metoclopramide should be used with caution, and then ondansetron dose should be 8 milligram once daily and maximum dose of 8 milligram twice daily. Anxiety and depression, because of the prolonged disease interval and progression of disease, many patients have these complaints of anxiety and depression. So, citalopram is used for anxiety and depression first-line therapy in palliative care setting, and it is basically the SSRI of choice in hepatic impairment. The general principle is the same, that aim for maintenance dose of 50% that is used in healthy patient, maximum dose of 10 milligram per day. But these SSRI can increase the risk of peptic ulceration and bleeding disorders. Regarding haloperidol, it is a D2 antagonist used in palliative care as an antiemetic as well as for delirium. It is a good antiemetic for many chemical causes of nausea and vomiting and after radiotherapy. And for nausea and vomiting, start with 500 microgram to 1.5 milligram per oral at night. And for delirium, mild to moderate distress, it is 500 microgram, and for severe distress, it is 1.5 milligram. Serenase can be used for intracerebral hiccups also. The dose of 1.5 milligram once daily or twice daily. So the first choice SSRI is citalopram, which should be given at the lower dose of 10 milligram once daily. The other option can be sertraline, and the palliative care of antiemetic can be haloperidol, can be used for delirium also. Regarding the antibiotic dosing in cirrhosis, liver is an important site of removal of blood-borne bacteria, and hepatic destruction of bacteria and reticuloendothelial system related phagocytosis are impaired in patients with cirrhosis. In cirrhotic patients, serum bactericidal opsonic activity and neutrophil function are defective, and this eventually leads to 5 to 10-fold increase in bacteremia in patients. So these cirrhotic patients require therapeutic and prophylactic antibiotics. Generally, the macrolide antibiotic like erythromycin, azithromycin, and clindamycin, which are excreted and detoxified by the liver, should be used with caution in these patients. Metronidazole, ketoconazole, micaconazole, fluconazole, itraconazole, and nitrofurantoin should be used with caution. fluoroquinolones can be used. And the next slide, this slide shows which of the antibiotics are safe in liver disease. Penicillin, amoxicillin, and clovulanic acid can be used. Clindamycin normal dose with hepatitis can be used. Similarly, clarithromycin with normal kidney functions. Metronidazole, when the liver function is stable, it can be used. Similarly, doxycycline and vancomycin can be used. Regarding metronidazole, in mild liver disease, prescribe the normal dose, but as the liver disease progresses, we have to decrease the dose of metronidazole to 50%. And if both the liver and kidneys are affected, it should further be reduced. Avoid tetracycline in liver disease. These are the antibiotics which should generally be avoided: chloramphenicol, erythromycin, tetracycline, because it leads to dose-related hepatotoxicity. The ATT drugs I'll describe in the next slide. Different combinations should be used. Similarly, nitrofurantoin has a prolonged use, should be avoided in liver disease. Now, anti-tuberculosis therapy is associated with hepatotoxicity in 10% of the recipients, and hepatotoxicity required withdrawal, maybe modification, and then sequential reintroduction to achieve the cure of tuberculosis. Cirrhotic patients with tuberculosis have significantly lower completion of rifampicin plus isoniazid-based ATT, higher hepatotoxicity, and higher mortality. Recommended ATT in child A cirrhosis is the same as non-cirrhotic population, but strict follow-up is required. Pyrazinamide may be avoided. But in child B cirrhosis, pyrazinamide should be avoided. Isoniazid with rifampicin may be avoided. And isoniazid or rifampicin with ethambutol and quinolone can be used for 12 to 18 months. But in child C cirrhosis, ethambutol, quinolone, and one of the second-line agent may be used, such as linezolid can be used for 12 to 18 months. Regarding the different anticonvulsants, the first-line therapy for patients with liver disease, levetiracetam, it is 66% excreted unchanged by the kidney and 24% undergoes enzymatic hydrolysis. No change in mild to moderate liver disease, but dose should be reduced by 50% in patients with child C liver disease. Lacosamide is also an option for the treatment of epilepsy in patients with liver disease. Similarly, topiramate can be used because it is predominantly excreted by the kidneys as unmetabolized drug. But with patients with severe liver disease, the dose should be reduced by 30%. Gabapentin and pregabalin can be used. The second and third line therapies, because they have multiple liver side effects, should be used with caution. Similarly, the anti-epileptic drug of last resort should be valproic acid and phenytoin. Regarding the different cardiovascular drug therapy, patients with NASH-related cirrhosis have increased incidence of dyslipidemia, hypertension, and coronary artery disease. Drugs like labetalol, captopril, amiodarone, and methyl dopa can cause severe hepatotoxicity. Statin is safe in patients with cirrhosis. Normally, patients with GI bleed and with varices, we use non-cardioselective beta blockers such as propranolol because it reduces the portal pressure. Hydrochlorothiazide and furosemide should be used carefully in liver cirrhosis because they may induce hepatic coma through their rapid diuretic action. According to different studies, ARBs and ACE inhibitors prevent the fibrosis in the transitional period from chronic hepatitis to liver cirrhosis. One of the very common complaint of patient with liver disease is pruritus. So pruritus can occur for many reasons. In liver impairment, a thorough history and examination is necessary. And cholestatic pruritus will be managed differently to uremic pruritus or opioid-induced pruritus. It is histamine independent, not effectively relieved by scratching, and it is unrelated to degree of cholestasis. Different antihistamines are the first-line drugs. Chlorpheniramine, which induces sleep without being woken up by pruritus, and loratadine is commonly used as first-line antihistamine. We have to reduce the dose in severe liver impairment, that is every alternate day dosing. For cholestatic pruritus, cholestyramine is used, and the reduction of serum bile acid level reduces the excess bile acid deposited in the dermal tissue. Cholestyramine is not recommended for patients with complete biliary obstruction, as bile is not secreted into the intestine. And this drug should be taken at least 1 hour before or 4 to 6 hours after cholestyramine to minimize the possible interaction with the different drug absorption. Cholestyramine can be used safely in patients with liver impairment, and the usual dose is 4 grams twice daily. Naltrexone is the next option that can be used in patients with pruritus. It is safe and effective in treatment of pruritus associated with severe jaundice. Dose of naltrexone in pruritus is 12.5 milligram twice daily, and it can be increased up to 50 milligram twice daily. Now, drug-induced liver disease is a very common cause of liver disease, and there are more than 900 drugs, toxins, and herbs that have been reported to cause liver injury. And the different risk factors that may predispose patient to drug-induced liver disease include female gender, age, genetics, concurrent disease, and polypharmacy. It can be divided into 2 categories: the intrinsic reactions and the idiosyncratic reactions. The intrinsic reactions are predictable, reproducible, and dose dependent, and tend to occur rapidly, for example by paracetamol overdose. But the idiosyncratic reactions are not predictable, they are not reproducible, and does not depend on the dose, and tend to take longer to occur, that is weeks to months. They can cause any type of liver injury resulting in increased liver function tests, jaundice, fever, rash, and eosinophilia. The drug-induced liver injury have different patterns. Acute liver failure can occur with allopurinol, aspirin, cyclophosphamide, and the NSAIDs. Cholestasis can occur with warfarin, azithromycin, azathioprine, carbimazole, oral contraceptive pills. Fibrosis and cirrhosis can occur with methotrexate. Phenytoin and isoniazid lead to acute hepatitis. Amiodarone, corticosteroid, and total parenteral nutrition leads to steatosis. Azathioprine and oral contraceptive pills can cause different vascular disorder, thrombosis. So this is just a summarized chart of my talk. So, opioid analgesia, sedative, antihistamine, antimuscarinic drugs can cause constipation, and they can further precipitate and worsen the encephalopathy. NSAIDs, aspirin, and bisphosphonates, these medicines can cause gastrointestinal ulceration and bleeding. Opioid analgesics, benzodiazepine, hypnotics can precipitate or worsen the encephalopathy. Medicine with high sodium content, the different N-sachet soluble tablets and some intravenous preparation, these can worsen the ascites. And NSAIDs and aminoglycosides should be used with caution because it can cause nephrotoxicity. So in conclusion, prescribing medicine in patients with liver disease is a challenging task. There are no clear tests which can identify altered drug metabolism in these patients. Medication should be individualized depending upon various factors. Surveillance using liver enzymes is recommended. The enhanced nephrotoxicity of radiocontrast agents, aminoglycoside and NSAIDs may be more frequent and dangerous challenge than hepatotoxicity. Thank you very much.
Thank you very much, Dr. Osama. The information that you shared with us would be of great help to all of us in different specialities. So we're going to open the floor up for questions or any comments. Yes, Dr. Mustafa, please go ahead.
Hi, thanks. Dr. Osama, thank you very much for the talk. I've just got one question regarding pain management in patients with impaired liver function. You said long-acting or drugs with a long half-life should be avoided. How long is long-acting? Because I've just noticed that there is a chart that you've shown where tramadol is BD, which is 12-hourly. So what is your recommendation? How long is long-acting and how short should it ideally be?
Yeah, basically a cutoff. Thank you, Dr. Mustafa, for the question. Usually up to 12 hours with a half-life of 12 hours can be given. But again, the general principle is that the dose should be reduced. For example, an NSAID should be avoided. So we can give the tramadol, but the NSAID toradol should be avoided. So the cutoff should be 12 hours half-life with reduced dose.
Thank you.
Do we have any more questions or comments? You can write it in the chat box if you want. Yes, Dr. Vakar, do you want to say something?
Yes, I just unmuted my mic. I was actually trying to speak before. So, Doc, thank you for the talk. I actually joined in the middle of it. I was called upstairs. So you talked about pruritus in liver disease, and you said cholestyramine is the first choice. How quickly does it start acting? If a person is like itching all over the body, and why I'm asking this question was my grandmother was recently she died because of liver disease, and she had a lot of pruritus, and all the local doctor prescribed her was anti-allergic medicines, and I didn't know. So I'm saying if you start a patient on this cholestyramine or antipruritic because it is a cholestatic pruritus, how quickly does it start acting on the patients?
Dr. Vakar, the first line is the SSRI. We can give loratadine. The second line is cholestyramine, and it usually starts in 2 to 3 days. It doesn't start within minutes or hours. It usually takes around 2 to 3 days to come into effect. But the first line is antihistamine. Then we usually give this cholestyramine, and then we can give naltrexone or different other options that have rifampicin can be given. But again, rifampicin has it can cause liver deranged functions.
Yeah.
So it can be given at 75 milligram or 150 milligram once daily. But the first option is the SSRI. The second is cholestyramine. Then we can give this rifampicin.
So in SSRIs, do you think escitalopram?
Yeah, escitalopram and loratadine can be given.
I see. Because the antihistamine that they were giving were making her more confused. So I did not know, and I did not have any other options. So we just had to stop it.
Usually in liver disease, when the patient is with pruritus, we start with antihistamine, then we start with cholestyramine. But again, cholestyramine usually give it effects after 2 to 3 days, but it should be started.
Okay.
But
All
one
right. Thank you.
thing is that it comes with the name of Custran sachet, and that was not available recently. But
I see.
it is usually prescribed.
Thank you.
Okay. कंफ्यूजन हो रहा था इसमें, ये मुझे बीच में काम नहीं कर रहा था.
Any more questions from the audience? Okay, I think we don't have any more questions. Thank you very much, Dr. Osama, and everybody else for your time and attention. So we're going to conclude this session now, and have a good day, everyone.